Welcome, everybody. Welcome to the second webinar of the PD Green Program Justice Education Series. I'm really excited to be with you this evening. My name is Chiara Benetolo. I am the Director of Program Development at the PD Green Program. And as many of you surely know, the PD Green Program is a nonprofit organization that supports the academic goals of incarcerated and formerly incarcerated people through tutoring and college readiness program. We span across 7 states and Washington, D.C., and we have been around since 2008, recruiting, training, and managing thousands of volunteers who have worked with students inside and outside correctional facilities, more than 60 correctional facilities and re-entry sites the last time we counted them. An important part of our mission is also to educate volunteers on the carceral systems and encourage them to engage in justice-oriented activism to reimagine the criminal legal system. And in fact, while our work focuses on education, it's really important for us that we understand and we share the many ways in which the criminal legal system affect the lives of the people who come in contact with it. In each of our regions, we partner with other institutions, with community organizations to offer education as part of wraparound services. And we're really excited this evening to bring to you representatives of 2 organizations that are doing amazing work on promoting health equity inside and outside correctional facilities. I want to just take a couple of minutes to set the stage before I cede the word to our amazing guest speakers. As we know, and as we will hear, treatment for both acute and chronic conditions is really often systematically denied to incarcerated people, and the consequences can last for a lifetime. In fact, each year that someone spends in prison can cut their life expectancy by 2 years. And medical neglect kills hundreds of incarcerated people every year. I think the recent COVID-19 pandemic compounded the impact of inadequate care and brought the issue to the spotlight. But as we will hear, there are so many different instances of this healthcare crisis going on inside correctional facilities and affecting the lives of people who are incarcerated and with effects that persist after their incarceration. So welcome again, everybody, and I'm sure I'm really looking forward to the conversations that we are going to have tonight on the issue of the health challenges that are posed by incarceration and unlocking healthcare equity. We will start by reading the testimonies and hearing some of the testimonies of people who have been directly impacted by the criminal legal system or who have worked in the system. And then we will hear from Rebecca Job and Sumet Sharma, who represent the Legal Action Center and the Correctional Association of New York. 2 organizations that really work in different ways and that often collaborate to fight discrimination and to promote equity for the people who are impacted by the criminal legal system in New York. We'll hear some of their presentations, then we'll have a brief conversation, and finally we will open up the floor for your questions and thoughts. So please mark down your questions. There will be time at the end to ask them. And thank you. We're going to share our screens. In preparation for this webinar, We reached out to some of the people that we know and have been impacted by the criminal legal system and have experienced health discrimination. As an organization, it's really important for us to do everything we can to spotlight and elevate the voices of the directly impacted people that we work with. So while they were not able to be present in this webinar, we recorded their story, and I'm going to read a couple of them as an introduction to the rest of our session. So this person shared that the medical unit in the prison was really only good for 2 items: bacitracin ointment and cold setups. For some reason, it seems they felt bacitracin fixed everything. Any injury I sustained inside was not properly evaluated and left untreated. I was refused adequate care and could not get the exams I needed to properly diagnose and treat my ailments. As a result, lots of pains have persisted to this day, and those issues began over 10 years ago while I was still inside. This is the testimony not of an incarcerated people, a person, but of a medical professional. I know of prisoners with cancer have been treated with nothing more than Tylenol. A recent Columbia study found that 90% of inmates with hepatitis C did not receive the expensive medication they needed. Inmates routinely have to complain of the same symptoms multiple times before they even get to see a doctor, sometimes waiting weeks. There's no doubt that prisoners have faked illnesses and escape attempts during medical transfers to hospitals, and this is a real problem. But often the default attitude among guards and other staff is that inmates are lying about being sick. I once had a patient in prison with liver cancer. Staff videotaped him working out in the yard to prove he was a fraud. He died a month after I was finally able to treat him. The man had rectal bleeding over a year, and it was never taken seriously. And to conclude this section, we are also going to play an audio recording from a formerly incarcerated person, Mr. Morgan, who came home in August this year. You can listen to the full recording using the link that we are going to put in the chat, but we are just going to play a short snippet for now.
Yeah. So, Mr. Morgan, can you tell me a little bit about your experience with healthcare while you were inside?
Yes, I certainly can. The healthcare in the correctional system it needs an overhaul. I noticed that there was a lot of laws, protection laws, as far as the inmates, as far as their medical conditions and stuff being exposed to, told to other people. Like, for instance, I noticed that a lot of times when we went to medical, the nurses, some nurses, the older nurses they were racist, and they didn't mind discussing your medical conditions with the officers there, which they're not supposed to do that, but they did that a lot. I also noticed that when it came to emergency, like if there was an emergency in the housing units, they were very poor in responding to the emergency. A lot of times the officers would come with a van and have the inmates load you up in the van, and there was no nurse or no doctor with them. And as a result of that, a lot of times people just didn't get the proper response time that they should have been given.
Thank you. So I think we have already heard a lot from those people, and certainly more could be said. And I really encourage everybody to follow the link and check out the entirety of Mr. Morgan's stories. But we're already seeing people's health concerns not being listened to, being systematically ignored, and out of a number of fears that I think we hear quite often that are not necessarily justified. And also something that I would love to explore more in our conversation afterwards is the role of medical professionals who work within the system, who can counter some of the systemic discrimination that we're seeing, but can also and oftentimes end up reinforcing them. So without further ado, I'm going to cede the floor to Sumit Sharma, who works for the Correctional Association of New York. He is the association director, and in this role, he advances the Correctional Associations of New York's policy and communication goals. He focuses on sharing the association's research funding, data analysis, and policy insights with the aim of shedding light on the state's prison condition. His efforts extend to engaging with elected officials, the advocacy community, and the public through media channels and direct partnerships with individuals and organizations that are committed to driving change in the state prisons. Sumit, thank you so much for joining us tonight, and I really look forward to hearing more about the role of your organization.
Well, thank you, Kiara, for setting the stage for us, and appreciate, being here with Rebecca and Andrea from the Legal Action Center, and everyone from the PD Green program. We, as the role of the Correctional Association of New York is to provide monitoring and oversight and disseminate information to people who are interested to learn about what's happening in the prisons. We particularly appreciate opportunities to speak about what's happening in prisons, overall, but tonight related to healthcare. I pulled together, some slides that, that I'll go through in a minute, that just reviews of sort of the background around CANI, and then healthcare related findings, and then policy recommendations related to healthcare and prisons. Wanted to start by just, just like to take from Mr. Morgan's words and setting the stage. Like oftentimes, we see that, administrative data or data being released from the prisons isn't entirely accurate and doesn't paint a complete picture as to access to healthcare in prisons, access to mental health care in prisons, and the actual administration of policy. So, even though, we advocate for these policy solutions and changes for what is happening related to healthcare in the state's prisons, the reason that the monitoring and oversight is important to CANI is because we're able to see the implementation of how things are going and the voices on the ground, and the way access to healthcare is limited or isn't changing in prison. So, excited to jump into some of that in the slideshow, but just wanted to say that to you. So, to begin, the Correctional Association of New York was founded in 1844. It's an old organization, and it was one of the first organizations to provide oversight of prisons from civilians. So the Correctional Association of New York isn't appointed by any sort of state official or the governor or so on. Through that law that was passed way back when, we're able to visit state prisons and report on prison conditions. Currently, the way we need to operate under the law is we could visit any state prison within 72 hours by providing 72 hours notice to docs. We could communicate confidentially with incarcerated individuals and prison staff on these visits. We could operate a phone hotline for the reporting of prison conditions, offer surveys to incarcerated people and staff, and then we're required to disseminate reports and recommendations to the governor, legislature, docs, and the public at large. And we have to visit each prison every 5 years and issue a report from these, from the monitoring and oversight. Some history. Right, founded in 1844. It's sometimes mind-boggling how long some of these advocacy efforts take when looking at it on a historical perspective, and some of changes that take place. There was right a ability to for incarcerated people to allow access to Medicaid coverage upon release from prison that was passed in 2007 that Canny played a role in. We're just digging into some of the history that we see over through time. As I think we were looking at a report from the late 1800s that recommended that the department don't place people in isolation for more than 14 days. That was published by Canny back then. And in 2018, the State Assembly, and then 2 years later, the entire legislature ended up passing a limitation on the use of solitary confinement with the HALT Act that placed a limitation of people being in SHU units to 14 days. And that was right after like a decades-long advocacy campaign. But just I think puts into perspective some of the time it takes and effort it takes for policies to be enacted. The way the Correctional Association conducts oversight is through prison monitoring surveys, communication with incarcerated people, and data collection and analysis. I just want to sort of go through that because some additional detail here. On our monitoring visits, they're generally 2 to 3 days. We're permitted to bring 12 people, inclusive of staff, volunteers, board members, a number of impacted people and people from advocacy organizations. During those visits, we conduct interviews directly with incarcerated people. We visit special housing units, general housing units. Just yesterday, a team of county representatives was at Mohawk Correctional Facility and spoke to people who were in the special housing units and the residential rehabilitation unit, which are disciplinary units in the prison, but also looked at the food processing facility in the prison, which is where they make sort of this cooked shell, which is this pre-processed, pre-packaged food that they then distribute across state prisons. And that's part of a look towards trying to get a better understanding of the availability of nutritional food in prisons and trying to shed a light on the food making process. And essentially, the preliminary report is that it wasn't a clean facility. It was, problematic as far as nutritional content and the quality of food in a number of ways. So, an example of an issue that we're looking to report on the future and how our monitoring visits play into it. And from June 2021 till the end of last year, we were able to visit 14 prisons across the state. Part of that includes visits to the state's regional medical units, including Bedford Hills, Coxsackie. More recently, we went to Wendy. And then additionally, a part of these visits were oriented towards monitoring the implementation of the HALT law as it came into effect. So upstate, which you see is number 7 on this map over here, is very close to Canada. And something that we see particularly in prisons in that region is that there's a lack of access to medical care as a result. There just not being enough doctors and nurses in the region for docs to recruit. Right, I mean, medical care, access to medical care is seen throughout the system, but just a note, as we're talking and going through the slideshow. These are some photos of our visiting teams. We receive phone calls, letters, email correspondence from incarcerated people, family members, advocacy organizations, and other stakeholders on a daily basis. Right, while the Correctional Association doesn't provide direct services in urgent situations, right, we do directly report to the DOC's Office of Special Investigation, as well as the State Inspector General, to ask for an investigation and then make referrals to legal organizations and direct service providers. But we also take the information that we're receiving from prisons to implement it in our reporting and a look ahead towards what people are writing to us about to be able to plan our monitoring visits and decide where to go to in the state as far as being responsive to urgent issues. We like to preserve our 72 hours notice to docs. But for example, so this example I'm giving of like a future visit, maybe we could keep it in this in this program. But there was a suspension. We saw a news report and received reports from incarcerated people about a suspension of emergency ambulance services from the town of Beekman, which is where Greenhaven Correctional Facility is located. That's been in place since August. Based on the information that we've asked for from a few different entities, it seems like there's a lack of clarity on what's going on there. So, that's an example where, hearing about correspondences from people is very helpful in better understanding where we could go to better monitor occurrences in the state prison system or incidences in the state prison system. We also use administrative data for the analysis of our information and for our reporting. Last month, we publicly released under custody unusual incident and data about the deaths of people dying in prisons on our website. There's a screenshot over here, and I pulled some takeaways for the next slide. But if you'd like to visit the website, click around. There's a lot of information in there. You can download the spreadsheets too, but it's correctionalassociation.org/data. We also enhance our in-person monitoring by deploying surveys by mail. This was particularly helpful during the pandemic to better understand people's treatment and access to medical during COVID-19, along with a survey that we did in 2022 on the grievance report. These are the reports I mentioned earlier about each prison. We'll get into some of the findings soon. And then we also issue reports on we also disseminate reports on specific issues, including on vaccine hesitancy in state prisons, healthcare across the three states in the COVID-19 pandemic, and then outside of healthcare on the HALT law that I noted and the grievance process in prisons. So what our reporting comes out to and all that process on essentially going on the visits and taking a look at data are what we hope to be are findings that better illuminate the lack of access to adequate medical care in prisons, as well as mental health services um, in prisons. We ask people on our prison visits, yes or no questions based on people adequacy of mental health care. For example, we asked across 3 prisons, Elmira, Albion, and Orleans in 2022, whether people had experienced or witnessed an emergency medical or mental health situation at their respective prison. And 55% of people responded yes to that question. And in many instances, people described, the response to emergency medical or mental health situations as delayed, harsh, or inadequate. The reports themselves, provide specific details, which we take care to, de-identify from an individual who is reporting the detail to us. It's outside of there not being emergency medical response from the town on Greenhaven right now. Some of the instances that are detailed in the reports themselves are, one detail is about someone who suffered a leg injury and was not helped up and sort of left in place, but then was also had staff from the prison sort of mock the person who had just injured themselves, sort of adding just another element to, right, there being, even if there is sort of access to emergency or medical health care, there being inadequate treatment for people in crisis. Similarly, at 3 prisons, Bear Hill, Upstate, and Elmira, which where 2 of those, Bear Hill and Upstate, are way up for Canada, reported 58% of the level of medical health care as adequate, which is pretty low percentage. That being said, at Great Meadow, 32% of people reported the quality of general health care to be adequate. When it came to mental health care, we had similar findings, of the people who do receive mental health services from the Office of Mental Health in New York. There still had been people who were reporting to us that they had attempted to hurt themselves in prison. With 23% of people at Great Meadow and Clinton reporting that they have attempted self-harm, and 13% at Bedford Hills reporting having attempted self-harm, which speaks to some of the conditions of incarceration and the dearth of mental health services and needs. Administrative data is another way that we could gain insights as to what's happening in prisons, administrative data is, in a sense, opaque. We are advocating for better reporting from data from docs on data for information about people who are dying in prisons to be reported with regularity, and to include the causes of death to better understand the things that are leading or the reasons why people are dying rather in prisons. From the administrative data, quick look, we saw 54 so far this year. There have been 54 people who have died in New York State prisons, with 7 of the people who had died being below 40 years old. We also have a chart here about where people are dying in state prisons, and this is over a course of, I think from 2020 to 2023. But the prisons with the most deaths are prisons with what are called regional medical units, which are prisons with large hospitals, essentially, that provide advanced medical care to people. This is an indicator that of people who are dying in prison, a significant percentage of people are dying from health-related conditions and regional medical units, and that is to us an indicator that perhaps medical parole, compassionate release, and other means to provide for people who are medically ill to not be in prison and be released aren't being utilized to their full effect. I just wanted to touch on some of our findings from the survey that we conducted in 2020 and 2021. And the title, "My Greatest Fear is to be a lab rat for the state," which is a quote from someone we spoke with on the prison visit. But you could take a look at the numbers here as far as levels of trust that people have in healthcare providers to make medical judgments overall. When we asked through the survey, with 45% of people saying yes and 55% of people saying no. And then when we asked, about trust within healthcare providers in a prison, that the numbers fell drastically, with only 12% of people saying that they trust healthcare providers in prison. This affected the ability. This affected the intake rate of people, electing to take the COVID-19 vaccine during the pandemic. It also, illuminates, I guess, a larger issue around access to healthcare in prisons, which is trust within a prison healthcare system, or the DOC's prison healthcare system specifically. Just pause here on some of the quotes of what people wrote to us as part of this survey. I mean, a variety of perspectives, but essentially, there's never been adequate care, and the healthcare is negligent, irresponsible, and uncaring. And we also had a report where we compared the responses to the COVID-19 pandemic across 3 states. As far as people being tested for COVID-19, and then vaccination rates. We could see in the chart on the bottom over here that New York State is significantly behind the other 2 vaccination, the Illinois and Pennsylvania, and it's and the percentage of people who had elected to take COVID-19 vaccinations. New York was one of a few states that chose not to include incarcerated people as part of the earlier phases of people to get vaccinated in the state. And as a result, you see New York lagging behind Pennsylvania, Illinois. They were behind states that you wouldn't imagine would also be ahead of New York. And this healthcare, back then, providing vaccines earlier to people in prisons. And then I think I I think we have time, but just wanted to touch on the policy agenda that we published last year, and some of the initiatives that we're supporting in the following year. And one of them is legislation to expand the health department's review of correctional health services, including a study on healthcare staffing at facilities. This is based on some of what we saw around vaccine hesitancy in prisons, the lack of trust of correctional health staff, and an eventual hope that the Department of Health assumes the responsibility for healthcare in prisons from the Department of Corrections and Community Supervision. Another look, and there's more policies listed on our website of bills that we're looking to support, is expanding mental health access to mental health services for our incarcerated people in prison at large, since currently DOCS only provides access to mental health care for people with specific diagnoses. This bill would essentially recognize incarceration as trauma upon mental health, and provide access for mental health care for all people in prisons in New York. We also look to support more facility-based recommendations in our reporting. One of those that I pulled, was to expand approaches to peer support programs, to allow incarcerated people and people from community-based organizations to provide healthcare and access to information on healthcare, to address a lack of trust in correctional healthcare staff, and the lack of availability of services in prisons. And then before the thank you slide, I just wanted to talk a little bit about what we're looking to work on in the next year or so, and related to healthcare, and that's a look towards issuing reporting on food access and nutrition in prisons. They have limited the availability of food packages in prisons in the last year, and commissary prices have been rising for the cost of food, and we're hearing continually about how people in prisons don't have access to food and are hungry. So would like to, or we will be issuing a report on that. We're also trying to take a closer look at the causes of death for people who are dying in those regional medical units and overall. We're having some trouble accessing that data from the department, but would like to see a better understanding of what's happening in the regional medical unit and in these prison hospitals. And then lastly, and maybe this is a good segue, looking at the medication assisted treatment program, which was a law that was passed last year, that provides for MOUD treatment, and I'll leave it to Rebecca to explain the details on that. But it is something that is oriented towards providing a medical treatment towards towards people who have elected to take part in the program for substance use. And part of making sure that this program is effective is making sure that the department rolls it out with by making sure people are aware of this program, making sure that the people who are enrolled in this program are actually receiving the treatment, and that there are enough resources there to support the program at large. So we're looking forward to seeing whether those things exist, and then reporting on them, whether they do or don't. So thank you for listening. I appreciate
Thank you. Thank you for sharing so many insights into what the organization does, but also the landscape of really the many needs that are unaddressed inside correctional facilities in New York. So it did give us the perfect segue to hearing from Rebecca. So Rebecca is a senior staff attorney at the Rebecca Job is the senior staff attorney at the Legal Action Center. She advocates for individuals who experience discrimination because of their drug use, arrest or conviction records, and HIV or AIDS status. Rebecca works with the Legal Action Center, impact litigation and direct legal services across all those areas, but with a focus on legal and litigation strategies to increase access to medication for opioid use disorder and to enforce anti-discrimination rights for people who use drugs. So thank you, Rebecca. We really look forward to hearing your perspective on the work that you do on those issues.
Absolutely. Thank you so much for having me, and to everyone for attending. So I'm gonna talk a little bit about Legal Action Center and what we do. As Sumit said, we're gonna kind of go from like a broad picture to really focusing in on access to medication for opioid use disorder. So, talking about this kind of one health condition, but then we're gonna talk a little bit about ways in which the legal protections can be applied to other situations as well as other disabilities. So a little bit about the Legal Action Center. We use law and policy strategies to fight discrimination and build health equity for people who use drugs, who have conviction records, and who have HIV or AIDS. And so we provide free legal services throughout New York. I'll talk about that a little bit more on the next slide. We also do impact litigation, which basically just means trying to bring a case to establish some new thing to have the courts interpret a law as applying to a situation in a new way. That can then be used by other people to advocate. And then we also do policy advocacy training, and we work in collaboration with other organizations. And so here's a very quick overview of our legal services in New York. If you know someone who's experiencing any of these things, or you are, our number is right here, so you can call the office to get connected to a paralegal. And we also have this flyer that's linked. But for people who are experiencing barriers to employment or housing or other sort of civil sort of opportunities, I'll call them, but we provide legal services for that. So if someone is being told that they can't have a certain job because of their conviction record, that is something that we work on and that we represent people in. And we also do criminal record review to help people understand what's on their rap sheet so they can go about, applying for jobs or housing and knowing what maybe they need to disclose and what they don't need to disclose. And the other thing I'll say is we also do licensing work. So if someone with a conviction record is going through the process to become licensed as, like a security guard or a social worker, we represent people in those hearings if they have a hearing. And so then to move on to our work that we do for people living with HIV, a lot of this is privacy work and discrimination work. And so we provide legal services if people feel that they've been discriminated against or that their privacy has been breached, essentially, that their status has been disclosed without their consent. And then for people with substance use disorders or who use drugs, which is what I'll be talking about a lot today and which is what I work on most, we work on enforcing anti-discrimination laws, both through legal services and litigation. And we also work on privacy and insurance issues. So again, this is our number. please reach out to us if you need help, or if you're a provider and have questions, we're happy to do any of that. So to kind of give an overview of, why this is important and why making sure that people have treatment for substance use disorder is important, I kind of wanted to just give this overview of the overdose crisis. And, the Legal Action Center, we believe that we need a destigmatized approach and a public health approach to dealing with substance use and addiction. And that so people shouldn't be criminalized for these things, but that we need to approach substance use with a public health approach. And this is so important as the numbers of people who are experiencing overdose death continue to increase. And that's in recent years seen a rapid increase among people who are Black and people who are Native American. And so that's the context in which, it kind of orients us to why it's so important that people have access to treatment. And MOUD, medication for opioid use disorder, I think has been focused on for a couple of reasons. One is that opioid overdose deaths have greatly increased in the last few years. Although with fentanyl, we know it's not just opioids that people are overdosing on. And so that's super important. But that's kind of one of the reasons that there's been this focus on medication for opioid use disorder. And then the other reason is that there's not a lot of medications to treat substance use disorders, but there is for opioid use disorder. And so when we think about treatment and all these overdose deaths, one of the sort of terrible elements of this or aspects is that there actually is a medication to treat it, but most people don't have access to medication for opioid use disorder, even though it is a life-saving medical treatment. And that just gets amplified in the criminal legal system. New York has done some work to address this over the last couple of years. And so we'll talk about that more. And so I kind of see the role of the legal work as making sure that people have access to recovery, working on reducing stigma. I'm going to tell everyone a little bit about anti-discrimination laws. Hopefully it's not too much, but there's so much stigma about substance use and addiction and other disabilities, but that is evidence of discrimination. And so what we're doing through enforcing these laws is in part really challenging the stigma that people use to make decisions instead of making decisions about healthcare that are based on clinical standards. And then the other thing that we're trying to do is reduce criminalization and, really advocate for policies that treat addiction, mental health needs as needing a public health response rather than a criminal one. And so I said earlier is in just a couple seconds ago, that New York has been doing some work on access to MOUD corrections in the last couple of years. And so there's this new-ish law that I think it's just about a year actually that it's been in effect. It went into effect October 2022. And it gives people the right to methadone and buprenorphine in New York jails and prisons. And so all jails and prisons are required to provide access to medication for opioid use disorder. And I'm not sure if everyone knows what that is, but medication for opioid use disorder is in very short, typically given through two medications, methadone or buprenorphine. And what it does is it stops withdrawal, which is really important because withdrawal is both physically and mentally agonizing. It also stops cravings so that people are able to stop using illicit opioids, quote, unillicit. So those are the two, sort of really important medical things that medication for opioid use disorder does. It really allows people to enter and sustain recovery. So the New York law, here are the very broad requirements. It first requires that all forms of MOUD are made available in every jail and prison, except there is one exception. So the all forms means methadone, buprenorphine, and naltrexone. But for some jails, there's a limit on, or there's an exception if they're unable to provide methadone. We won't get too much into the details of that, but methadone has to be dispensed at what's called an opioid treatment program. And those are very regulated, and so they're hard to open, and so they're not everywhere. And so some jails are just not in the area of a methadone program, so that might mean that they don't have to provide that medication. Okay, the next thing that every jail prison is supposed to do is provide a medical screening for opioid use disorder and the need for medication for opioid use disorder. They are supposed to create a treatment plan that is individualized to each person. They can't say everyone coming in is getting 8 milligrams of Suboxone. We've heard of that happening in some facilities. The treatment plan is supposed to be individualized to the needs of that person. If everyone's getting the same dose, that's kind of a red flag. This is important. A qualified health professional is to make all decisions about medication type, dose, and duration. And there are supposed to also be discharge planning and transition services, either between facilities, like if someone is going from a jail to a prison or transferring prisons, and then from a facility into the community, so there's continuity of care and people aren't starting a medication and then not being able to continue it once they're back in the community. And then this is, I think, really important, and is like I'm glad that the law includes this, because I think it gets at some of the really problematic thinking that we have in healthcare and in corrections, particularly, that it's seen as sort of a privilege instead of a right. And this last provision is getting at this, where people aren't supposed to be denied admission or removed from a program because of any disciplinary infraction, including but not limited to positive tox screens. So this does happen, and it has happened in other places at least. But what's important to remember is that MOUD is healthcare. It's not, like I said, it's not a privilege, and it's not something that should be taken away because of some other, technical or disciplinary infraction that someone might get. So that was a summary of the New York State law that mandates MOUD. I wanted to mention, because this is what Legal Action Center has also worked on, is that there are other federal laws that also prohibit the denial of medication for opioid use disorder. And so denying MOUD violates the ADA, the 8th and 14th Amendments to the Constitution, which prohibit cruel and unusual punishment, which in the medical context means deliberate indifference to a serious medical need. And the ADA, which I'll talk about a little bit more, prohibits discrimination against people with disabilities. And so these cases basically say that denying medication for opioid use disorder when is denying access to a jail's medical program on the basis of someone's disability. And the cases have also said that denying this medication, which is a life-saving medication, is cruel and unusual punishment. And so that's just something that's good to keep in mind here. And there's been 4 cases about this, and 2 of them have actually been in New York, in Jefferson County. Okay, so I'm not going to talk about this too much, but the information is here. I wanted to just talk about the anti-discrimination laws a little bit more, because they provide protections for people who are incarcerated, and they also provide protections for folks who are not. And the Legal Action Center does a lot of work on this in many different settings. And so anti-discrimination laws say that a person with a disability cannot be denied an entity's services, programs, or activities because of their disability. So to give an example, in a different context in the criminal legal system, if someone's on probation and they're told that in order to be on probation, so in order to access this program, you can't take medication for opioid use disorder. And so that is discrimination based on the person's disability because they're being denied the program based on the medication that they're taking for that disability. So that's just an example. And there's a bunch of anti-discrimination laws. There's some in New York State, but they apply to most settings. So they apply to the criminal legal system, they apply to jails and prisons, to courts, to probation offices. They apply to family courts and the family regulation system or child welfare system. They also apply to healthcare entities and to employers. And so everything I'm saying about the ADA in this context would also apply to all of those other contexts. And so this is just a little bit about who has a disability when you're talking about a substance use disorder. So a disability has a very specific definition under the laws, and it's an impairment that substantially limits a major life activity. And so if someone has, opioid use disorder, for example, the impairment is opioid use disorder. And the substantial life activities might be something like neurological functioning, brain functioning, caring for yourself, thinking, concentrating, that sort of thing. So every person has to show that they have a disability under the law. But this is just a little summary of who is protected. So on the one hand, people with disabilities are protected from discrimination. And so there's some examples here, like someone taking medication for opioid use disorder, or someone with another substance use disorder, or someone with a mental health need also has a disability. And so other areas that Legal Action Center works on these laws are in the criminal legal system. I just gave the example of probation or like drug court saying that you can't be on MOUD, that's illegal. We also work on employment cases. So if someone's denied a job because they're taking MOUD, that's illegal. And so we work on that. Or if someone's otherwise denied because they have a substance use disorder. And then the other setting I'll highlight is healthcare. A lot of people, this is like very ironic, but have barriers to getting healthcare for their healthcare need. Hopefully that irony makes sense. But we often see people being denied admission to skilled nursing facilities because they take MOUD, or they're denied some sort of home care because they have a substance use disorder. That is illegal, and we work on that. And so please contact us if that has happened. I'll leave you with one thing about the ADA if you remember this, but stigma and decisions that are made based on stigma instead of legitimate medical considerations, that is typically a sign of discrimination. So if something's happening, it's kind of like a sniff test. If decisions are being made that are just based on like what medical evidence says and what that individual's experience is, that's often a red flag. And yeah, I'll end there. So thank you, everyone. Here's our legal help page, also where you can get tons and tons of resources. Thanks.
Thank you, Rebecca and Sumit. Was really interesting and depressing to hear your presentations, but also fantastic to hear all the good work that you are doing to address those needs. So I'm going to open up the floor for questions in a couple of minutes, but I want to take the time and the privilege of being the moderator of this panel to ask a couple of questions myself. The first thing that comes to my mind is we've heard a lot about the great work that you are doing to promote health equity inside correctional facilities, but it's also really interesting the ways in which you are receiving messages from the incarcerated people who are advocating for themselves, who are self-organizing and getting in touch with your organizations, it seems. So I wonder if you could speak a little bit more about that. We know, in every facility, there's someone who, serves as maybe an informal teacher, whether they are teaching, workouts to fellow incarcerated people or mindfulness, or whether they're working in the law library to advocate and help other people advocate for their health access. So I would be really interested in hearing more about the ways in which you have encountered those forms of self-organization and self-advocacy in your work, and how do they fit within the broader and more institutional efforts that you are conducting?
So one of the things I touched on in the slide were peer-based support programs. And the reason why that is like a key, I guess, area that we'd like to see expanded is because, from what I understand from Charles Muhammad, who told me some of the history of it and who worked at Canny for 10 years, that this program was essentially something that was organically started in a women's prison in New York, where people wanted to take it upon themselves to help each other better be informed about access to like treatment for HIV, hepatitis C. I think those were the two areas to begin with. From that, the state developed a policy sort of replicating that program and bringing it to other places in the state. But but that stopped sometime in the 90s, and it hasn't been expanded to other areas too. But having peer-based support programs to provide information about access to medicine, what are areas for concern, and then having taking it another step and making sure that there's that communication between like the peer support organizations in prisons and medical providers to be able to provide that information and support is something that's important to us. So, but yeah, no, through our correspondence, unfortunately, like we hear more about a lack of access to medical care and a lack of access to treatment and more emergent concerns. That's the nature of that.
Rebecca, did you want to add anything? I saw you briefly raised your hand, I think.
I actually didn't have anything to add to that answer. I was trying to open the Q&A and I raised my hand. Sorry about that.
Sounds good. No, of course. And I'm seeing a lot of great questions popping up in the Q&A already. So I'm actually going to move right into those, and we can continue the conversation if we have time later. But there was a question that has been sitting in the chat for a while that I'm going to take and expand. It is, do other states have oversight organizations like Caney, or how are other state prisons monitored, if at all? And I'm going to tweak the question to ask the same of Rebecca in terms of how are you connected to other organizations who may be doing similar work in different states? How does that work?
Just quickly, there's two other civilian oversight organizations in Pennsylvania and Illinois, and some other states do have like state appointed oversight entities, New Jersey, Hawaii, Arizona being some of them.
Yeah, we partner with organizations across the country and work with them to, because a lot of protections are federal laws and so on, federal enforcement and interpretation, and on sort of trends and best practices. We definitely look to what's happening around the country.
Thank you. We have another question, I think more specifically for Rebecca, that is, in order to be protected by MOUD laws, does the state determine who is categorized as disabled with an MOUD?
Yeah, so to be protected by the MOUD law, so for the New York and corrections law, it would protect someone who has opioid use disorder and needs medication. And that would be determined under a clinical assessment. So it's diagnosed, and then an addiction specialist will prescribe the medication. For the federal laws, so for anti-discrimination laws, there's a definition of disability, but each person, and this really only comes up if you're trying to like assert your rights, if that makes sense. It could come up in the context of, requesting a reasonable accommodation at work, not to get too into the weeds, but I say that because substance use disorder is generally considered a disability, but technically each person has to say, I have an impairment, and that's limiting my major life activities. I hope that makes sense. And the impairment could be many, many different things. It could be a physical disability, it could be a mental disability. And so, but the point is that each person says, this impairment is a substantial limitation of my major life activities. And often enough, that is true for substance use disorder. So we just kind of say generally it will qualify as a disability.
Thank you. Thank you. And then I think I really like this question that was asked by another guest. How can medical schools be more proactive about securing health equity in the carceral system? And again, I'm actually going to build on this and ask about how can we all become more proactive about securing health equity in the carceral system. Obviously, everybody is going to have a different role. We're not necessarily going to be able to go out and fight for people's rights in the same way that you do, but what can everybody do if they want to advance this this cause after they've heard this webinar?
That's a really great question. I'm thinking about it a little before I answer, but I think medical schools can play such an important role in providing some education that's often not provided in the context of medical schooling. So something that we see a lot, and I'll just talk about what I know best, which is, addiction. Medical schools often don't do anything about addiction. They don't, it's not part of the standard curriculum. And so I think making sure that medical schools are, addressing the sorts of stigma and bias that they're not free from. You grow up, you're raised in this culture, you're educated in a culture that stigmatizes certain people and certain conditions, and unfortunately the healthcare system just isn't immune from that. And I think that there needs to be real dedicated time to thinking about stigma and addressing how you're approaching certain people, and that the assumptions that you're making about them that aren't valid at all. And just, I think that there's a tendency within correctional settings to really just dismiss people and say they're not, and not take their healthcare needs seriously. I mean, someone wrote in the chat about dental care, and I think it's just this sort of laziness and not putting resources into it and just being like, well, whatever, it's not that big a deal, we don't need to prioritize it. But really sort of challenging that stigma that I think plays a really big role in a lot of what happens.
I could add to that, Rebecca. something. Yeah, I mean, there's a sort of direct advocacy that we would encourage folks to take, in the sense that to advocate for non-correctional health practitioners and oversight of healthcare services in prisons, and to bring people with health expertise into prisons through policies. So specifically to engage with elected officials on the state level and contact them in support of changes that would allow for healthcare policy to be determined by people who aren't hired by the Department of Corrections and Community Supervision, and the review of the administration of those policies to be with experts. That being said, I think that, like Rebecca, to your point, it's a larger discussion, conversation that needs to happen as to the priorities of people overall and the public at large on changing the conversation around the stigma of people who are incarcerated receiving their right to adequate health care in prisons. And even sometimes right, with conversations and advocacy with the people who are responsible for these policies, there is a lack of political will overall, and other considerations that come into play. So I feel like, yes, there is that direct advocacy that, regardless of the lack of political will, let's encourage people to make and take that step. But that being said, if there's individual acts that we could take to help people and to provide support as that conversation changes to within our own circles and networks, and discussions like these, is something that's critical too. A final piece on the dental, since we touched on that. I want to Richard's question. We do see a lot of people who have a lack of access to adequate dental care in prisons. Similar to that statistic that I noted in the slides earlier about people responding about access to adequate medical care. We asked the same question about dental care and access to adequate dental care. I didn't, pull it for tonight, but they're actually in each of our post-visit briefing reports. And we're looking to make it a little more accessible by adding through the data sets that we have on our website. But just wanted to acknowledge that it is a significant problem that we do hear about this practice of extraction being used as the principal form of treatment for dental conditions in state prisons.
Can I add one more thought that I had just about this? I just wanted to say that in our legal work, the opinion of medical providers is actually extremely important, because you basically show people how important something is by explaining to them the medical condition. So if we're talking about stigmatized medical conditions like addiction, for example, people are just like, well, whatever, you're not getting medication for opioid use disorder, or you're just drug seeking, that sort of thing. And so intrinsic to like making sure that people have, that this law passed actually, and that the cases challenging these sorts of practices has been to explain why that's medically completely untrue and inappropriate, and how serious a condition is that's often written off. So I just want to say that, and that people in the medical field are actually wonderful advocates, and I think sometimes more effective or as effective as like lawyers, for example, and being able to just sort of show the practicality of why something's really important.
Thank you. It seems to me one of the takeaways of this conversation is really that there is such a strong link and a cycle between the criminalization of medical conditions, the stigma that comes with them that then leads to incarceration, and there's a furthered by the discrimination that people experience inside correctional facilities, that then oftentimes leaves them in an even worse situation after they are released, and the cycle continues. So really, I think it's really important to hear how, you know, the ways to address this cycle is by ensuring that people inside correctional facilities have access to adequate healthcare, but other ways are advocating for, you know, a systemic approach where we approach health conditions from a public health perspective rather than from a policing and punishing perspective. So that was yeah, that was really interesting and goes well with what we do as an organization around promoting education for people inside and outside correctional facilities as well. I think we have time for one last question. Sumit and Rebecca, if there is one of the questions in the chat that you feel particularly interested and inclined to answer to, please go ahead. Otherwise, I would love to hear from you how you both got involved in this field. I think that's a really an interesting question and a good conclusion. And what makes you passionate about this?
So I'm just looking at the other question, and you know, maybe I brought the link to in a sense. You know, my background before coming to Canny was in working for an elected official who had oversight over the state prison system. And as part of that, I visited prisons. And the first prison visit I went to on Sing Sing was, even though it was oriented towards showing, I guess, what the department was proud of at that prison, was just incredibly shocking. And it was, you know, alarming, to say the least, that there were that many people, you know, right on the other side of this wall that a Metro North train line runs through, that's on like the Hudson River, who were incarcerated in the conditions that they were in, and after that, sort of looked to work towards advocacy, and then found my way to the Correctional Association of New York, and looked to sort of create work to bring different people into prisons, and then report the conditions on what was going on outside. And, you know, prison healthcare is an area of our focus, but it extends to other areas too. And then just quickly, now we do have challenges with keeping, you know, regular communication with people we are incarcerated, with people who we speak with, who are incarcerated following visits, and we have to correspond oftentimes through mail and the phone, and there's limited availability to those services in prisons, which has a large effect.
So I actually got started working on this by working at the DC Corrections Information Council, which is one of the government oversight bodies that goes into the DC jail and also the Federal Bureau of Prisons facilities. And so I started sort of working there, and then I just really wanted to do a little bit more on the advocacy side. Yeah, I was very disturbed working there how low the bar is for healthcare for people and for anything really for someone who's inside. And like, you know, like the Eighth Amendment doesn't really actually, not to be too down, but like the standard of the Eighth Amendment is a little low in my opinion. And you know what you have to prove to sometimes meet that is just ridiculous. So I wanted to work on law enforcement, like not in law enforcement, but on enforcing laws a little bit more. And then it just, you know, led me to Legal Action Center that works on the intersection of a lot of sorts of things that I'm passionate about, and have been working a lot on, you know, healthcare access for people who use drugs, which is just a very sort of interesting place to be in because there's so much hypocrisy in it, and it's, you see the intersection of just so much stigma and prejudice and bias, and to the types of drugs that are stigmatized, the certain people who use drugs are really stigmatized and policed, and it's an intersection of race and classism. And I think just something that we, you know, as society really needs to change thinking about and stop moralizing and attaching sort of like a moral judgment to drugs and drug use, and using that to kind of maintain a very racist, classist status quo. So that's sort of a little bit of my passion on this topic.
Thank you. Thank you. And I think that is a wonderful conclusion for our conversation. So in wrapping up, I really want to thank you, Rebecca and Sumit, for joining us, for sharing your experience, your passion with us. I also want to take this opportunity to thank my colleagues, Sarah Irshan and Charlotte Saunders, who worked on the in the background of setting up all of this webinar, like all the other webinars of our justice education series. And we would and also thank everybody for coming, for listening to us, for engaging with all of your great questions. I am sorry that we were not able to answer all of them, but we really appreciated you engaging with us. Speaking of you who came to this webinar, we have a feedback form that we are putting in the chat, a brief survey that tells us how was this webinar, and your feedback is really important for us to continue to bring webinars that are relevant and interesting to you all, and to keep refining what we do. So please take a moment to fill out our survey form. We would also love to invite you to our next webinar, which is going to be on November 30th on another amazing topic, that is the LGBTQ+ experiences and identities in the age of mass incarceration, also at 6 p.m. Eastern time. I personally really look forward to hearing those that webinar as well, and I hope that you will be able to join us again. You can register for that at the link that we are putting in the chat as well. And finally, we hope that you remain connected with the PD Green program. We have a newsletter which we encourage you to subscribe. You can do so on our website. We are on Instagram, we are on LinkedIn, so please follow us so you are always updated on all our justice education series and all the other great things that we are doing. We are also hosting 2 events upcoming in the next few weeks. Next weekend, actually on October 28th, we are hosting a 5K walk run for educational justice in Princeton, in Boston, and virtually. So you can join us at Princeton, you can join us in Boston, but you can also hold virtual runs wherever you are. You can register for $40. You can also fundraise for your ticket. You can make a donation to support our runners and walkers. And finally, we are also hosting a gala, the Going Green, the Art of Educational Justice, which will be a celebration of our organization, but also of the creative arts and the wonderful art that is produced by people who are incarcerated. If you missed it, we did also have a webinar on art behind bars. It's on our website and I highly recommend it. But yeah, Going Green is going to be on November 18 in Philadelphia. But like the walk run, we are going to, you can attend virtually. There will be different ways of interacting, even if you're not able to make it to Philly. And you can learn more about all of those events through the links that we're putting in the chat. So thank you again, everybody, for joining us. I hope it was informative and that you're all going to go out and advocate for the changes that we need to ensure that everybody has the access that they deserve to mental and physical health care inside the correctional facilities and once they are released. Thanks again. Thank you again, Rebecca and Sumit. It was great chatting with you.